can type it over there. We can read the question and we can answer that. And even the moderator will be asking that question. So they'll be moderating. So without further delay, I would request Dr. Bhageshri to start. Dr. Bhageshri. Oh, now she is having difficulty.
Technical difficulty.
Okay. So I'll take. Can I take the chance? Tell you a few minutes. Yeah.
Yeah, madam. Yeah.
Yeah. Can I tell you? Yeah, about my status. I've got a call again. I hope we are not on air, or even if we are on air, because this is an explanation for why I need to go early. I've been called by the ICU again. As you would know, I am a caregiver to my sister who is suffering from Parkinson's disease. She's in the ICU now, and I have been called by the ICU to come quickly. But my brother, my niece is there, to whom I have handed over for a few minutes to be with her. So I will be cutting short my presentation, and I'm very sorry, but I don't want to just leave without coming and do my bit. My sister herself would not like me to do that. So if you would allow me, I will cut short and do the presentation. And I think all the questions can be answered by Dr. Joshi, by Dr. Robert, and the others, the professors who are here. They will be able to answer all the questions, I am sure. Thank you so much.
Thank you. Dr. Bhageshri, please start. Please switch on your, please unmute your mic over there.
Good afternoon.
Go ahead,
Good afternoon
please go
to
ahead.
all the ladies and gentlemen. RC Mysore chapter is started in 2012 under the leadership of Dr. Hanmantachari Joshi and a few like-minded people. Since then, RC Mysore chapter has been conducting various events throughout the year. In the month of September, RC conducts series of programs including memory work, screening camps, talk by experts, seminars, workshops, etc. Today, we have one such program with renowned speakers and guests. It is my pleasure to welcome you all to today's webinar. At the beginning, I would like to extend a cordial welcome to today's speaker, Dr. Laldinpuii Fente, Professor and Head, Department of Psychology, Mizoram University. We welcome you, Madam. I would like to extend a special welcome to Dr. Robert, State Nodal Officer, Government of Mizoram. We welcome you, sir. I would like to extend a warm welcome to the convener of today's program, Dr. Hanmantachari Joshi, Principal, Sharda Vilas College of Pharmacy and President, RC Mysore Chapter. We welcome you, sir. I would like to extend a cordial welcome to the members of RC Page Government Ayurvedic Research Center, Mysore, Department of Ayush, Government of Karnataka, Department of Geriatrics, JSS Medical College to this program. I would like to extend a cordial welcome to all the participants. Thank you. Now I would like to introduce today's guest. Dr. H.K. Dean obtained MA in Psychology from Northeastern Hill University in 1994 and in 2004 completed her PhD in Psychology from Mizoram University. She has been awarded with research projects like Research Project on Migrant Against HIV/AIDS, awarded by Mizoram State AIDS Control Society, Research Project on Violence Against Women and Related Issues for Human Rights and Law Network, Mizoram, awarded by National Commission for Women, New Delhi. She has received Fulbright Nehru Senior Research Fellowship in 2013-14 from Psychology Department, Princeton University, New Jersey, USA. She has supervised 50 PhD scholars and 6 MPhil scholars. She has published more than 25 research papers. She is Secretary for RC Mizoram Chapter. We are privileged to have you here as today's speaker, Madam. We welcome you once again. I would like to cordially extend a warm welcome to Dr. Robert, State Nodal Officer, National Mental Health Program, National Program for Prevention and Control of Deafness, National Viral Hepatitis Control Program. We welcome you, sir. Over to Joshi, sir.
Bhagesh, wonderful information. I think we have already exceeded the time, but let me do a small duty as you know the head of the RCI chapter here. We are highly thankful to Dr. Dini for joining with us. We have been seeing her wonderful activity for the purpose of the Alzheimer patients. Not only that, her credentials are very high. But I think it's not the time to keep on prolonging it because we understand the situation of Dr. Dini. A hearty welcome to Dr. Robert, Dr. Prabha Adhikari, and RCA Mysore is doing a small work, in the association with all these people. And thank you once again. And I request Dr. Dini to kindly start. Dr. Dini, please. Dr. Dini, can you please start your talk? Yes. Yeah. Meanwhile, I request all the other people to kindly mute their mic so that there is no disturbance. We can't hear you, Dr. Dini. Can't hear you. Can't hear you. We can see your screen, but we can't hear you.
Okay.
Yeah.
Can
now,
you hear me now?
Yes. Perfect.
All right.
Can you please give the slideshow so that we can see it better?
Okay, I'll put it in a slideshow.
Yes.
Okay, but it has taken over my entire screen. But it is all right, I think. Right. So first off, I would like to give my sincere thanks to the Mysuru chapter of ARTSI, Alzheimer's and Related Disorder Society of India, and especially to the convener, Dr. Hanumantachar Joshi, he's principal of SVCP and also president of ARTSI Mysuru. And of course, the moderator, Dr. S.R. Bhagyasri, and those that have been associated with these webinars, the Sarada Vilas College of Pharmacy, Mysuru, People's Association for Geriatric Empowerment, Government Ayurvedic Research Center, Mysuru, Department of Ayush, Government of Karnataka, Department of Geriatrics, JSS Medical College, Mysuru. And those who are in association with the ARTSI Mysuru chapter, I feel very, very grateful to them because it means that all these people are, holding hands with all the caregivers and the patients that we are going to talk about in this World Alzheimer's Month. Today I will be speaking about caregivers' mental health. First off, I would like, because so much has been spoken in the previous presentations, we have spoken a lot about, the dementia, and Dr. Robert Khawlring here, my colleague, who is also the Vice President of ARTSI Mizoram chapter, where I am the General Secretary, will be giving about, the symptoms of dementia and things. So I will be solely talking about the caregiver stress and the less talked about compassion fatigue, which often, bogs down the caregiver. Caring for Alzheimer's as well as people with dementia, others like the one that I am caring for, who is my sister, who is suffering from Parkinson's disease, and of course my mother, who was suffering from Alzheimer's disease. We are faced with unusual pressures and enormous amount of responsibility, because since they have motor as well as cognitive, difficulties, with memory and all the difficulties that is faced by dementia patients. A whole lot of things rest upon your shoulders, physically and emotionally. Therefore, it becomes very, very exhausting. You have to adapt to changes in the person you are caring for, and you have to develop new skills. Each and every aspect of Alzheimer's disease and their behavior, and Parkinson's, although you can talk about, the symptoms, the development, the progress, and all of that, in general, each individual is unique. So therefore, you need to develop new skills, unique ones, in order to take care of each unique individuals. And this progresses and leads to increasing amount of responsibility as the disease progresses. So caregivers suffer high levels of stress, and these severe stress takes a toll on the well-being of the caregivers. High risk of burnout, and there is high risk of burnout, and may suffer from both physical and emotional problems. And of course, prolonged stress is known to contribute to depression, a weakened immune system, high blood pressure, heart disease, and other negative health outcomes. Now, many of us, when we are into our caregiving so much and concentrating so much on the caregiving part and the illnesses, we tend to forget ourselves. So it is sometimes possible that we do not know that we are facing stress and that we are burnt out even, unless physiologically or physically illnesses happen to you. Like it often happens to me time and time again, as I do caregiving for over 15 to 20 years now. So it is good to see ourselves. If there are caregivers amongst us today, it is important to see, to check whether we are really stressed. It is always good to introspect and see for ourselves. So as there are 10 points given here, all caregivers, I would request you all to give 10 points for each of the symptoms of stress, the signs of stress that is given here. And out of 100, you will be able to see, we are very used to 100 points, right? The first quartile, the second, the third, and the fourth. People in the last two quartiles above, the third and the fourth would have serious signs of stress. So one is denial. Denial that it is not really, as this is especially at about, stage one, when it is diagnosed, then, you are not really accepting it, and you are in denial. And also the denial about, the disease of that has, come into the family, denial of that, and also denial of your own stress. And anger at, the disease, anger at the family, anger without reasons. And then social withdrawal, you don't want to be with anybody, like other times. If you are very introverted and does not socialize too much, even then, your level of socializing, your level of socialization would go down. Even if you are an introverted person, you are not cooped up in your room all the time. There's a little bit of, social in us, even if you are very, very introverted. So that's number 3. And then anxiety, and then depression. You don't even have to explain these. And exhaustion without, having explanation for why you are exhausted. You're just exhausted, and you are sleepless, and you wake up in the middle of the night for no reason at all, and you are very irritable, or you have bouts of, temper throwing, people around you would be like, on their edges too, because you are irritable all the time. And then there is problem of concentration, or you cannot really concentrate about your work, or about your studies and things that you do in your office. And the number 10 is health problems. For example, a weakened immune system, high blood pressure, aches and pains, the stuff that I am going through now, that I'm trying to get out of, and other negative health outcomes. The care and the caregiver, that is the patient and yourself, if you are a caregiver, basically we are on a shared journey, but we have different prospects. We have different future. You need to say, that one is pretty morbid and sad. People with dementia or people with Alzheimer's, there are changes in cognition and emotion and motor functioning, which is progressive, and there is no cure at the moment. On the other side, there are caregivers, changes in mental health that we go through. Sometimes we are so... Hello? Or am I audible?
Yes, madam, you are audible.
Okay. Is it?
Yeah.
Because
Madam, can you just slide
Yeah.
is it the same, or madam, which slide are you in now?
I am in...
I just scroll down, madam.
Okay. So I'm scrolling down. I am on the care and caregiver, a shared journey but different prospects. Are you able to see this?
No. No.
Okay, let me just... Okay, is this...
Yes, now we are able to.
Yeah, okay. So I will not do full screen then.
Okay, please.
All right. I think
Yes,
it's all right to do.
Yes, we are able to.
This way. All right.
Yes.
So the care and caregiver, a shared journey, but different prospects. Right. So, whereas for the people that we care for, the future is pretty morbid at this time because there is no cure as yet. But for the caregivers, the changes that we go through and what the stress and strains that we go through is very severe, but it is preventable. We have 2 to 4 times higher rates of depression than normal, than non-caregivers, 3 times higher rates of anxiety and physical changes in health for the caregivers as compared to the non-caregivers. But, which one is preventable? Basically, the one that is the part that is being taken by the caregivers. But it rests upon the caregivers to take action because we need to be well for the people that we care for. Right? So, like, say, for example, my sister who is having Parkinson's disease in the ICU, and and I was not well yesterday and day before, because I've been so stressed and I've not been taking good care of myself. So I feel like I'm the right person to speak about this, because I have so many personal experiences where I have failed and what I need to improve, because you cannot be perfect all the time, right? And to try to be perfect is also not too good. But anyway, this is what you know, a researcher in this is the research that was done by UC Berkeley, University of California, Berkeley, by Professor Levinson. This is they had you know, 107 patient caregivers that had come in, and they you know, they tested them on the CESD, that is the depression scale, and they found that you know, quite a good number of caregivers of course have depression. However, it's like a normal probability curve almost. That only some caregivers are bogged down with depression, whereas others have no symptoms at all. So the question was, why is this? You know, they are burdened with the same kinds of stress and strain, and yet some people develop mental illness, whereas others are pretty fine about it. So the question was, why? Is it like that? Why are some people affected and why some are not? On the patient side, this is another research that was done by Levinson. Depending on the caregiver's health, the longevity of the patients also increase or decrease based on the mental health of the caregivers. So a healthy caregiver's cared for patient lives longer, they found, than those ones that are cared for by a caregiver who is suffering herself from mental health problems. And another research that was done by Professor Levinson was, you know, the lack of we focus pronouns. If the caregiver feels that the path is taken together with the patient, and instead of using a lot of I or using a lot of you, those caregivers who use a lot of we in the explanations and descriptions of their caregiving turn out to be to have you know, more better prognosis in terms of their path to mental wellness. So and why are we different? Again, this is another research, same you know, same results that has been found by another university research. So basically, whether we are able to keep, whether we are mentally healthy in our caregiving depends so much on the caregivers themselves. So, you know, it rests upon ourselves. So it is good, right? It is me who can do the changes. I can give, I can do the caregiving, and I also can care for myself, right? I think it is good to give credit to oneself when you are able to do so much, because, you know, God has given you that potential. You know, it is in you, but it needs to be filled, and it needs to be emptied out and filled and emptied out again, filled with good stuffs. You know, even caregiving can be wonderful. It can be it can be a very pleasing experience, actually. So, such feelings of positivity as you go through your, caregiving is the fill up of, positive emotions, so that you can give better care to your loved ones and to others. Unless we love ourselves, how can we love others, right? Unless we have a lot of love within us, how can we give that caregiving out, right? So the first step is to recognize what you can and cannot change. A way to control the stress of daily caregiving is to learn to recognize the things that can be changed for the better and to accept the things that cannot. So many experts that I have read through, the many, webinars and, literature and books, many experts offer the following advice. So learn everything you can about Alzheimer's disease, if it's Alzheimer's disease or, Parkinson's and the other dementias, so you will know what to expect and won't expend unnecessary time and energy worrying about things you cannot change. Accept the inevitable, live in the moment, mindfulness, and let go of unrealistic expectations. Your acceptance will enable you to concentrate on finding ways to cope. Don't expect a person with dementia to relearn information already lost, because you know why. Because you have already learned about Alzheimer's, right? Once you have learned what to expect from the disease, look for sources of help, such as local, state, central services, adult daycare and respite services. Now also in Mizoram, we are very, very happy that many people have, turned on their TV, where they see, the artsy people talking about Alzheimer's and dementia, and they have come to us, contacted us through the, the TI, the targeted invention of the NMHP that we are, the phone numbers that we give. So we have quite a number of members in Artsy Mizoram chapter also, and assistance. So make a list of these resources and keep it in a handy place. Find and join a support group, like the Mysuru chapter, like the Mumbai chapter, and all the chapters in India. It is wonderful, and of course, Friends of Artsy also. We do not have one as yet, but we should be having one soon in the in the far off places, meaning in the villages. Use validation rather than confrontation. This is very, very important, I think, because when you try confrontation and when you try to shout or give them explanations and descriptions and lengthy ones, and they don't even understand, who is going to get frustrated? Not the patient, but you, right? So so it use validation, but not confrontation. Create a safe and calming environment, simple, regular, routine, and following it daily. Locate sources on how to Alzheimer's proof the home for safety. Say, for example, in the middle of the night, you're afraid that they will walk out because, day and night does not make a difference too much. Biological rhythm and all of that, it changes. So it is important to Alzheimer's proof or dementia proof the house. Alzheimer's proof, especially because they tend to wander, especially in the evening when sundowning happens, all the symptoms are there. So it is good to proof the house with that. However, it is important to see the wellness of the people that you care for, that it is not too restrictive, their rights as human being, their dignity, all of that needs to be seen. and then do the legal and financial planning, the will and things like that as soon as you find out about, because these tend to bring about a lot of problems within the family. And it is important to recognize when your loved one or the patient you care for is no longer able to do things. So your attitude is extremely important. Whenever you're feeling overwhelmed, you have to practice a positive attitude. There are a whole lot of other steps to reduce, but I will go forward and tell you a little bit about compassion fatigue that we hardly ever talk about. Is a state experienced by those helping people or animals in distress. It is an extreme state of tension and preoccupation with the suffering of those being helped to the degree that it can create a secondary traumatic stress for the helper. So these are the symptoms. I will give my presentation. The symptoms are isolation, emotional outbursts, physical ailments, the them and us mentality, substance abuse, sadness and apathy, flashbacks, and things like that. And the causes are basically other directedness. We give ourselves too much to others since we were young. The people who are caregivers tend to be the ones who learn early in life that they are, responsible for the rest of the family. And, those people who tend to have this natural caring characteristics, and on the road to healing, we have to be authentic. We have to ask for help in time, like I asked for help today to my other family members, and we have to strengthen ourselves, embrace spirituality. I think Madam Vidya Shinoy had spoken about this yesterday, and be mindful and grateful. This gratitude, and attitude and gratitude, I find in my experiences, and spirituality, of course, are those that have helped me through all these caregiving experiences that I have had. I'm sorry, I need to go now. I think I also, when I am into these, talks and things like that, I go on and on. I'm a teacher, of course. I am like this. I'm sorry if I've taken up too much time. And of course, I need to go also. And thank you so much for the opportunity. Mysuru chapter, I hope we meet live next time, after, Mr. COVID-19 left us. Thank you so much, and all the best to everybody. Thank you.
Thank you, madam. Thanks for your wonderful speech. It was very, very informative. You said that longevity of the person depends upon the health of the caregiver. It was very, very informative, which we were never come across. And you said that impact of the using the word of me and you in place of we will also makes huge difference. It was very important. And you said that accepting the ones which we cannot change. It was, and introspecting ourselves. It's worth. It's, there is a lot of takeaway from this speech. Okay. Thanks for your time. Thank you. Thank you so much. Now I request Dr. Robert sir to take over. Sir? Sir, we can't hear you.
Now is it okay?
Yes, sir. Yes, sir. Please go
okay,
ahead.
So I'll start all over again.
Okay, sir. Please.
Thank you so much, Mysuru chapter, for having me today. I thought I was audible. I had already thanked you this the second time, but of course, it is endless that I should thank you.
Yes.
I'm very, very happy that that I have been invited. I'm, as I said, I'm not a full-time teacher. I'm just a part-time teacher, and I shall be most of the time talking about what we face and see clinically. So if there is any doubt, we can always talk about it later on. The topic as given to me was signs and symptoms. So first of all, I would like to, I know that most of us would have known the difference between what signs are and what symptoms are, but nevertheless, just like to give a little bit of insight to this. As we know that the presentation, whatever presentation the patient comes up with, that is what is, say, very subjective, which the patient comes up with would be symptoms, and whatever the observer or the caretaker or the clinical psychologist, the psychiatrist sees would be the sign. So sometimes what happens is the signs and symptoms are both similar, and therefore there could be slight say misunderstanding. But right here for this particular presentation, we'll be talking of signs and symptoms together, like as if they're happening together, because like I said, it could be the same. Just for example, I'll just give one example. One example would be that of, say, fever. The patient can come and tell you that they have fever, whereas the doctor or the physician or the nurse can also see that, okay, the fever is really there. So it could be both subjective as well as objective. Nevertheless, since we are talking about dementia as a whole, we shall go into this straight away. Now, as we see this picture, it is very clear. It gives us very clear picture that dementia itself is it's a very broad term. It is an umbrella term which is used to describe a lot of symptoms. It is more like a syndrome rather than one disease. And every time everybody comes up with, they usually say, I was asking my co-workers here, I said, okay, what do you think of when the first time you think of dementia and say Alzheimer's disease? They would say that there is memory loss. So almost everybody associates dementia and particularly Alzheimer's with loss of memory, and that is quite true. It is quite true. However, there are so many other signs and symptoms which occur here, and there are so many things which need to be understood. So we shall be going into seeing them, and we shall also see what other factors determine this the signs and the symptoms. Okay, so in clinical practice, say we diagnose dementia by the following ways that is written on the screen. We see that there is a syndromic picture. There is, like, we understand the signs and symptoms. We understand that there could be a lot of neurological testing that is going on, and from there we can diagnose. We also know that there could be other tests, psychological testings. There could be radio imaging, and from there we can also understand that there's a lot of changes that occur in so many of the radio imaging techniques that have now come up. And of course, ultimately the postmortem evaluation will definitely show what the person was having at any point of time. So for that matter, since we are talking about the clinical approach, so we should talk about the signs and symptoms. Very briefly, like the previous speaker, Professor Dini had already talked of all this. So it makes my work so very easy. And by just saying that, okay, there is a memory impairment, there's a deficit in language, there's a deficit in motor functions, there's deficit in recognition, we can say that executive functions are changed, personality changes occur. Now, it seems so very easy to say that, but exactly how and what determines at a point of time is different. What I mean to say is that when a patient is brought, or when the patient's caretakers, when they come and bring up the patient, usually it's not the same. The picture in say patient A will not be the same as in patient B, C, or D. Why? The reason is we will see those reasons later on. I will say in the later part of the presentation. So the cognitive and behavioral impairments that are seen have already been described, but nevertheless, I'll just go quickly onto it. The first point is kind of very important. This is very important because it is an inability to acquire and remember new information. Now, when we talk of memory, we can talk of memory in many terms. When we can talk of memory in terms of duration, we can talk of we can talk in terms of the say how it functions. For example, it could be procedural, it could be declarative, it could be like implicit, explicit, or in terms of duration. When we talk, it is usually immediate memory, recent memory, and remote memory. And what we need to understand is that it is the immediate memory that's the first to go. Then, of course, the recent, and then, of course, immediate, recent, and then remote. So remote is the last to go. So sometimes patients come up, or the relatives of the patient, the caretakers come up and say that this particular patient, I think he's lying. He is not telling the truth because he remembers so many things that have happened a few years back or a long time back, but he's pretending not to know what is happening as of now. So in that case, we have to tell them that no, if at all it is dementia and that has started, then immediate and recent would go first. So thereby, we have to understand that the patient will probably also try to confabulate. The patient will also try to cover up at times. So thereby, the patient may seem like as if he is a bad person. It may seem that the person is lying purposely. But we need to understand as caregivers that it is an illness rather than person being of a bad character. And of course, we have already talked of impaired reasoning. All sorts of reasoning go off. The person does not know, and therefore the person doesn't understand the consequences of things. And then, of course, there is impaired handling of complex tasks. So daily activities, calculating things would be difficult. Handling complex tasks also goes along with poor judgment. Here, the person would not be able to be able to say understand social norms. They may not understand finances.
Sorry to disturb you, Dr. Robert. Sorry to disturb you.
Yes, yes.
Some echo is coming from someone. Can you please unmute other people except Dr. Robert?
Okay, now is it clear?
Yeah, still some voices coming. Some other person is talking.
Hello, can you hear me now?
Yeah, we can hear you well. Yes, sir.
Should I continue?
Continue.
Okay, so we were talking about poor judgment happening. So when there is a lot of poor judgment that occurs at this point of view, at this point of time, then we can understand that the person is on the verge of having or already has had dementia. And of course, as we know, there is impaired visuospatial ability. Now, the person who plays cricket would know that if at all you have to play cricket, you know how even fielding, you have to judge how far or close the ball is to you, or even while batting, you have to understand that how close the ball is to your body in order to hit it. Now, these people will not be able to do it because they cannot judge. The space and time is clearly haphazard here. So they are not able to judge here. And of course, the language functioning, as Dr. Dini has already pointed out, many times they do not understand, they forget terms of the objects, they forget the names of the objects sometimes. So it is difficult for them to remember and say, they know it probably in their minds, but they cannot interpret that particular substance with the name that it is called. So these things happen. And of course, as we already said, there are a lot of changes in personality. There could be a lot of fluctuations in the mood.
Dr. Robert, sorry, I'm intervening again.
Yes, yes.
So someone speaking loudly from your place only. Can you please ask them to, yeah. Can you please ask them to?
I'll just. Pizza. Hey, come rồi, nhắc rồi, thì này cho bạn ring. Oh, please. You can. Okay, is it okay now?
Yeah, perfect. Thank you so much. Thank you.
Okay. So maybe yeah. Okay, so mood is fluctuating, and there are changes in mood, suddenly going up and down within the same day. Also, the person's mood would be very hard to determine. At times, they would be very angry and irritated. There would be agitations, and at times they would be very indifferent. There is loss of drive. They just I mean, it's almost like they have comorbid depression sometimes. So at these conditions, I mean, sometimes it's very difficult for a young clinician to determine. So a very thorough history is definitely required to differentiate between major depression with psychotic features and dementia. And of course, then we have loss of empathy, and may have obsessive compulsive behaviors. They may have socially unacceptable behaviors. Like when I say this, the thing is, it has to be dealt and known that every society will have their own norms. So the norms that are in your place and my place would be different. But for them, like wearing clothes, removal of clothes in public, that is never the norm almost anywhere in India. So that becomes a problem. Say urinating and defecating in public may also be a problem. So those things can also be seen, and we ought to know that they are. I repeat, and again I repeat, that they are not doing this because they are bad or they are characterless. It's because they are ill. So having said that, we'll go to the next slide. As it is written here, we have kept it in such a way that like almost like the persons who have dementia, how do you differentiate and when do you say that they have a real problem? It will be when the ability to function, say in the work scenario, say in play, or in other scenarios, when it is interfered and there is a lot of problems, then it is usually the case, and then there we say the person needs definitely needs help, medical help. And of course there will be like we know previously they may have had a very good level of functioning, especially since it happens to people who are elderly. So usually they are whatever the personality was initially, that level of performing, even the performance goes down. This has to be understood, and when this happens, then we can understand that yes, the person is definitely now having dementia and needs help. And now the reason why I have kept it in stages is simply because we just stated that there are many in general we just stated that these are the many say problems that could happen. Now we are saying that how at which stage we would see what many for the viewers who are into say who are students. I would like to say that many different, even the textbook would give you a different picture. Some book textbook would give you a 3-stage, some would give you a 5-stage, and some would give a 7. Now that is not a very we don't have to worry about that. It could be simply as early, middle, and late stage. And even here, as we go on from stage 1 to stage 7, we'll see that it is almost divided in the same way. Now this particular slide shows stage 1, 2, and 3. I have purposely kept this together because at this stage, although we can see that the signs and symptoms do occur, there are no, there is no definite diagnosis of dementia as of now. So these can be termed as preclinical. So at this stage, we know that the person's problem has started, and we also know that symptoms are about to happen as given here. I will not write. I will not read each and every one. But like in stage 3, we find that there is increased forgetfulness. This part, there's a lot of difference. Like people keep telling us and asking us, what is the main difference between normal forgetfulness and say Alzheimer's? So here we also tell them that when everything else has been ruled out, a person does not have depression, the person does not have any anxiety, the person does not have say stroke or any other problem, and still has it. If that is clinical diagnosis, at that stage we can say that the person is probably having Alzheimer's. And to confirm it, like we said, radio imaging and other tests can be done. This is just a picture representing and showing that the green parts of the memory are intact in the beginning. They start getting lost somewhere, and in the end, most of it is gone. So stage 4 and stage 5, we can see, and I have purposely put them together because this can be considered somewhat that this is a stage. These stages are where the problems really start to happen. There is difficulty in concentration. There is decreased memory. The memory, like the problem which has started in stage 3 now becomes even more of a problem. Simple things, simple tasks like managing finances become difficult. The person is unable to travel to new locations, like we already said, that it's the new information that is the main problem. So here, traveling to a new location with, on their own is probably not something which is very advisable. So they should, if they do need to travel, somebody has to go with them so that there will be not much of a problem. So then in stage 5, we have major memory deficiencies. We see that daily activities are also hampered at this stage. Simple tasks like dressing, having a bath, preparing meals, and other things become a problem. Tying shoelaces, something like that. So these things become so prominent that people here, it is very, very clear, and memory loss is also very prominent at this stage. Going on to the next, we see that in stage 6, what happens is even further more deterioration, and we see that there's a lot of problem. Now here in this particular, what I slide as written here, I would like to emphasize that there is something like as simple as incontinence. So of both of bladder and bowel, and their ability, because the ability to communicate, the ability to speak definitely declines. So that may be a problem. So for caretakers, it is very important that they recognize this and beforehand they prepare themselves for this stage. This is just a slide showing that normal brain and dementia, because all these problems are happening basically because of the loss of the brain matter. Okay, and then the last stage, we go into the last stage. Here, as we see, there is very severe cognitive decline, and especially the ability to speak or communicate totally goes off, and the person requires help. You cannot leave the person alone at all. And at this stage, we can know that the person will not survive for a very long time. So therefore, all that can be done by the loved ones has to be done at this stage. Then, of course, this is something that I wanted to talk about. I thought that since you can get all the symptoms and signs from say textbooks, that part, it was something which we had already talked of. Now these are the determining factors which I thought is worth mentioning today. Like, what are the determining factors of the signs and symptoms? For example, the stage of the illness, like we said in the beginning, that when a patient comes to you, the two patients having dementia or Alzheimer's disease would not present similarly. and that is because of the stages that they could be. It could be due to something like the genetic predisposition, and the person's. This is just a slide showing that genetic predisposition could be something that is linked to chromosomes, particularly to chromosome number 21, 14, and 1. And of course, now they are saying that it is on the gene coding for apolipoprotein E with the allele E2, E3, and E4. Especially the E4 part is the one which is causing the problem, especially the one E4 variant on chromosome 19, which is also called by some people, some authors have called it the bad apolipoprotein E. So which is mainly linked to Alzheimer's disease, and thereby it causes a lot of problems, and causes something like impairment of episodic memory. That is where, as we have already discussed before, the ability to learn and retain new information. Then we go on to the parts of the brain and the neuron that are affected. For example, hippocampus, and of course the ventricular. There could be hippocampal atrophy, there could be ventricular enlargement or particular thinning, and of course the symptoms here are not very different from each other. However, there could be slight variation, and if you put more emphasis, the hippocampal atrophy, there you could see more cognitive decline along with emotional disturbance. Then, of course, the presence or absence of aggravating factors. If there is always a family problem, members of the family are not happy with each other, there's constant shouting, fighting, that causes a lot of problems. It aggravates the problem. If depression, if the person has depression, if there is a strange relationship with any significant person in the family, especially the spouse, that causes a lot of problem. If there is financial instability, if there are other physical ailments associated with this, particularly vascular ones, which causes a stroke and other problems. Then, of course, some studies also say that low educational level and no cognitive stimulation is responsible and causes aggravation. And of course, as we all know, physical inactivity, sedentary lifestyle, these things are general terms. Now, I'm not saying that by doing this, we can totally avoid Alzheimer's disease or dementia per se. But nevertheless, by doing this, maybe the progression can be delayed, or the progression can be slowed down, although there is no cure for it. And we also know that there could be sleep disturbances. So this is one factor. Again, if the person does not sleep properly, if there's too less sleep, or some other disease that is causing too much sleep, or something that is causing irregular sleep, that could have a problem. There is a lifestyle factor, for example, smoking, alcoholism, and of course, unhealthy, unbalanced diet. That could be an aggravating factor. Now, relieving factors are kind of very important, because we also know, like already stated in the aggravating factors, if you treat properly dementia, depression and other mental associated mental illnesses, then thereby the person's condition could improve, likely at least. And then, of course, conditions like, as we said, hypertension, diabetes, obesity, dyslipidemia, all these, if it is controlled, then we can definitely relieve to some extent. We have to provide good psychosocial support and maintain a healthy lifestyle, especially in the first few stages. If we intervene, or even before that, if you intervene, then definitely we could either slow the process, or say even delay it to a certain extent. So the presence of protecting factors here, like we already said, I'm repeating myself, I know, but since it is so important, a healthy diet, good quality sleep, physical exercises, mental exercises, it's not written here, but active mind exercises is definitely important. And then, of course, socially integrated lifestyle, socially integrated lifestyle. These things are kind of because every society has their own say social activities. So I'll just tell you a little bit about Mizo society. We have MUP, which means Mizoram or Mizo Upapol. Though they are those people who are the elderly, and they are quite active. If they maintain that network well, then the person usually has a chance of having a good social support. Similarly, something like that could be present in every society whereby persons can somehow be protected. And then, of course, leisure activities has to be maintained well. Like we know that the mind is like a tree. Whichever is whichever branch is stronger would be bigger, and thereby if you wanted a lot of branches to come, we have to prune it in such a way and grow it in such a way that there are a lot of connections to each other. So the same way, if there are a lot of activities that a person can do, for example, if the person is a singer, then if they can remember lyrics, if they can know music, then definitely it is a protecting factor. We of course, like already said, promoting cognitive stimulation. So here, exercises that would connect the left side of the hemisphere of the brain to the right side of the hemisphere of the brain through the corpus callosum. That connection, if it is very strong, then thereby the person could have the memory loss would be not so severe. That's what speculations are. I don't know practically whether it is applicable, but nevertheless, it is said that as long as that connection is strong, the person's mind would be strong. Then, of course, we have already discussed about spirituality. Dr. Denise said about it, and I'm quite sure the other speakers in the previous days have already spoke about it. So we'll not go into details now, but it is kind of a very, very important factor and a protecting factor. And then, of course, we have also talked about comorbid factors. There are many, many more comorbid factors other than what I have written here, but these are some of the most important ones that occur in the patients of Alzheimer's or dementia, like delirium itself, depression, type 2 diabetes, vascular diseases, and of course, obesity. Uh, we keep telling people that it's good to diagnose early and treat early. Now, why would we say that? It does not have any cure. Nevertheless, at this point, like it is always good. I'll go to the third point. It is always good that if you can educate the caretaker. Now, the caretaker burden, like already the previous speakers have said, if this is reduced, and to somehow the quality of life will improve both for the caretaker as well as the patient. So early intervention is kind of very important and especially during the early stages of the disease. Here is just a slide telling you that it is beyond just the care of the brain. The individual has to be taken care of as a whole. Now this like it is more it's easier said than done. I know, but sometimes we, as doctors, also forget. We sometimes tend to treat the investigation. We sometimes tend to treat the disease, but we have to treat the patient as a whole, not just the investigation or the diagnosis. This is a slide showing that we have ARTC Mizoram chapter that was officially begun in 2017. It is near the house of our previous speaker, our general secretary at Electric Way. And we also, the services that we provide are counseling and guidance for families and the caretakers, and of course 24/7 helpline. These are the three helplines that we have established particularly for Alzheimer's and other mental issues. That's all for now. Thank you so much. Like
Thank you, Robert. It was an excellent talk.
Okay.
Yeah, Dr. Bhageshri. No, we can't hear you. You please switch on the. Please unmute.
Yes. Sorry. Sir, you spoke about the differences between signs and symptoms. Normally, we do think that signs and symptoms are one and the same. It is very informative for a common man's point of view. And actually, you said that E4 that is present in chromosome 19 will be helpful for identifying whether the person is having dementia. Sir, can we use that as a biomarker?
Definitely, this is one of the biomarkers that is coming on in researches.
Okay.
Although this is still in its very early and infancy, we can say, but definitely this will be this will go a long way, I hope, to mark Alzheimer's disease.
Okay, sir, you said one more thing. There is chromosome 14 and 21. I think that is one more.
Yes, 21,
parameter.
14, and 1. Yes.
Oh, yes. Okay. Okay, sir, and it was very informative with respect to the stages of dementia. I spoke about the signs and symptoms also, and it is very nice, good to hear that Mizoram society is having a network of people who are having who are able to do creative work together. So they'll be able to join together and they'll be able to work together so that they'll be working for common interest. So similarly in Mysore also we are planning to have one such. Actually, it has been initiated. Dr. Pratibha Madam is here with us right now. We have one such organization called PAGE, that is for geriatric empowerment. I think we'll be able to get some guidelines from you people and we'll be able to work towards the well-being of the elderly people of Mysore as well. And I heard that even Japan has one such. That's what is one of the reasons for the longevity of the Japanese. Not only with respect to life, even the quality of their life is also much better compared to other parts of the world. So I think we can take some inputs from your Mizoram society, and Mysore will be able to take guidelines from you, and we shall be able to help our people. Thanks for your wonderful speech, sir. Thanks a lot.
Thank you so much.
Thank you, Dr. Robert, for your time. Pratibha Madam, can you please unmute your mic there? Dr. Pratibha. Pratibha Madam. Bhageshri Madam. Hello.
Hello, sir. Hey, sir.
Introduce ಮಾಡ್ತಾರೆ next speaker na.
Okay.
ನಾನು ಪ್ರತಿಭಾ ಅವರು ಮಾಡ್ತಾನೆ.
Good afternoon. Today we have one more renowned speaker with us, Dr. Prabha Adhikari. A warm welcome to you, ma'am. Dr. Prabha Adhikari completed MBBS from KMC Hubli in 1980 and MD in General Medicine from KMC Mangalore. Madam has obtained a PG Diploma in Geriatric Medicine from IGNO and a PG Diploma in Clinical Research from Catalyst, Bachelor in Public Health from University of Alabama. Dr. Prabha Adhikari has more than 30 years of teaching experience and has guided 11 PhD students, of which 8 completed their PhD. Madam has more than 200 research publications and has co-authored 36 papers which won national and international awards. She has created 8 centers for active aging in the city of Mangalore and also set up 7 free diabetic clinics catering to the needs of 2,000 elderly diabetic patients. She was in charge of 60-bedded geriatric palliative care at KMC Mangalore for last 22 years and runs a comprehensive geriatric clinic at Yenepoya Medical College, Mangalore. Currently, Dr. Prabha Adhikari has been working as Secretary of Spurti Charitable Trust for the elderly, and she is Vice President of PAGE, People's Association for Geriatric Empowerment. Mysore RC chapter and PAGE welcomes you, ma'am. We are happy to have you here as the guest of today. We request you to share your experience and knowledge.
Okay.
Pratibha ma'am will be joining soon.
She has joined now. Pratibha. Madam,
Hello.
please switch on your. Madam, namaste.
Yeah.
She is there, yeah. Pratibha, madam. Hello.
I have joined
Pratibha,
Dr.
madam.
Prabha Adhikari.
Oh, madam, welcome. I think it's Dr. Prabha Adhikari.
Yeah, I'm here.
what is
Can
the
you hear
madam?
me?
Yes, we can hear you, madam. Can you please switch on your video?
Yeah, I have switched on.
Yeah. Yeah. In your absence, we have already introduced you, madam.
Okay.
Yeah,
Because I was
kindly,
there as a listener, I rejoined as a speaker.
Thank you so much. Thanks for that.
Thank you, ma'am.
Please start, madam.
Actually, I had the intention of showing a documentary which we had made with the support from NIMHANS. But due to technical reasons, I won't be able to do that. So I thought I'd give a presentation on the personal experience of managing my own father who had Alzheimer's disease. And after that, what we have done in the city of Mangalore for patients with Alzheimer's. I'll just share the screen. I hope the slides are visible.
Yes, they are visible.
Yes, madam. Yes, madam.
Yeah. As I think all the speakers have been saying, there are lots of palliative care needs of a patient with dementia, and I am going to tell you the story of my mentor, my hero, and that is my father. So how we suffered, and then how we accepted the diagnosis, and how we went ahead, having including him in everything that we did. Despite so much of awareness and RDC and its activities, we still see that this is how the patients with dementia are at homes, because the relatives are unaware of what to do with such patients. And I have seen even most educated people keep them inside the house, tie their legs and hands and keep some food for them, and then they go for work. So there's so much of lack of awareness on how to manage a patient with dementia. And all of us know that the figures of dementia are rising all over the world, including India and developing countries. And most of them will be in low and middle income countries, and unless we are prepared, we are going to see misery all around us. So I had the first-hand experience of dementia when my very active father started showing signs of dementia. Both my parents were very, very actively aging. My father, you can see here, with my daughter, with whom he is very fond of and playing, and my mother, who's also very active. They have worked all their lives in bringing up the children, and my father professionally had reached the highest level as principal of a government college, and he was the most efficient principal. And although he retired at the age of 55, he engaged himself in many of the social activities and started many forums for senior citizens, many forums for disabled, And also he was the founder of a home for the aged, and he did so much for senior citizens. He was a member of what is called as Probus Club, which was a club called for professional and business men and women, and many other activities. And he was very, very active. He was also teaching in evening college and then law college also. Until the age of maybe 75, he was extremely active. And then it happened that he lost vision in one of the eyes, and the other eye also vision was fading. That is where his cognition started fading, and we did not know, because it was just like suddenly when he had an acute illness, he would have what we call as delirium. That is, acutely he will forget certain things for a short while, and then he would recover and come back. And then he would function in a particular way. Although my mother had noticed certain changes, but she thought it's a part of aging and she did not share with us. The first time I noticed that there was something wrong was the wedding of one of my sisters, and he had some money left, and it was almost like whatever, when he had retired, he had some money left, and he was also into stock business, and he had some money left, and he thought he wants to give a diamond earring to my sister and to all the other daughters who were married also, and he had brought those diamond earrings, and he asked us to he brought it to us, and we said, why did you waste money on this? We don't need this, and you should keep it for your old age and for my mother. He was very upset, and he was not talking to us for a while. And first time, my father is a very strong person. We saw him having tears in his eyes. That was something which he would never show his emotions to us. So that's the first time I felt that there's something wrong with his brain, and it's not his normal behavior. From then on, there was slow deterioration, and we did not know what it was. There was some deterioration. He was, although he was very active, he tried to withdraw from most of the things. One by one, he said, I will withdraw. And we were not sure whether it was because of the failing vision or whether there was something else. So, after he started withdrawing from most of the things and social connect, then the stages came where he was behaving suddenly abnormally for a while, and then he would again come back to normal. So he would talk about something of the past, and then again he had to be reoriented to bring back to the present. So we took him to as many doctors in the city as possible, including neurologists, psychiatrists, physicians, but nobody would agree that he had something called as dementia. They would always call it as delirium or something like that, and they would ask us to search for a metabolic cause, and sometimes we would find it, sometimes we wouldn't find it. So it went on like that, when a day reached when my father started saying that there's a stranger in my house. And when we asked who that stranger is, he would point to my mother. So my mother, who was there caring for him, she would become a stranger, especially in the evening hours. Evening when I went home, he would say, there's a stranger in my house, so take all these belongings of mine and you keep it with you. And next day morning, he would again remember that the lady is his wife, and he would say, give everything back to me and I'll keep it safe. So this would occur for some time. So when it went on like that, I felt that there's something wrong and I have to take him to a higher center. So we went to NIMANS for assessment and evaluation. So that was the first time we learned that this is what Alzheimer's is all about. So a diagnosis was made that he had Alzheimer's. Although it was a big shock to my mother, and she didn't want to accept, didn't want to even utter the word, I was there, I accepted it, and then I started planning everything for him. So I remembered that I felt that he needs to be with his old friends, whom he remembers still. So I started collecting his old friends. About 7 to 8 people were still alive, although he was 80. There were some people around. And we started a center in our own hospital, that is KMC Hospital, where I collected them together and started a daycare center where friends would collect and do exercise under the supervision of a physiotherapist. That was a great help. Then I arranged for help for my father, because for my mother actually, who was distressed and who was very much upset that he was not recognizing her, by having a caregiver, initially in the daytime and later on even at nights. That reduced the caregiver burden of my mother to a great deal. Although she was very reluctant to keep another person at home, she finally agreed for it. And then things were much better. And I started understanding what Alzheimer's was only when I started observing my father. From then on things were much easier because we knew that this is what's happening and we could do a lot of things and keep him active until the end. So let us now, in the next 20 minutes, let us look at the palliative care needs. Although the disease is not curable, my father did receive, was the first one to receive the cognitive enhancing medications from NIMANS. He was the first one to have received rivastigmine, and he did pretty well with that rivastigmine for quite a while. Where he was not recognizing my mother, he started recognizing her, and that was a very great help. However, the effect was there for some time, after which it started fading. And then we had some other issues with his comorbidity and a lot of other problems. But however, it was much easier to treat him after that. So let us review what are the palliative care issues and what we can do for patients with dementia. How to recognize pain, because they do have lots of pain and we think we don't even know about it. And how to manage aggression and whether there are any indications for antipsychotics. So this is my father here. You can see who's with his own friends in an exercise center. Of course, he wasn't doing any exercise at that time, but just by being there with them comforted him a lot. And he was the most regular person coming to the exercise center. So as his stage advanced a little more, he did have a fall and he had a head injury, and he could not walk anymore, he could not talk anymore. But still, we could bring him to the Center for Active Aging, and he would also go to the speech therapy, which was helping him a lot because the children who were coming for speech learning were also with him, and they would call him Aja or Grandpa, and they would sit on his lap, and he used to enjoy that a lot. A very good bonding he had developed, because I would drop him there where all the kids would come and hug him, and again as I would take him back, those kids also would be there saying tata bye bye to him, and that was a very helpful thing for him. And similarly, he was going to physiotherapy regularly after the general exercise that the group was having, and every physiotherapy student went through him, and he was kept for many exams, and he would cooperate so well for the exams, and he would find it very useful. Actually, at that particular moment, he had lost his speech, but still he would enjoy that interaction with students, being a teacher all his life. So when we talk about palliative care issues, we focus on physical health, emotional health, social health, and spiritual health. The physical health in my father or a dementia patient, it is initially memory, cognition, speech, orientation, mainly to deal with that in early stages, and later on it will be doing activities of daily living. In the early stages, they are capable of doing it. In the middle stage, they require assistance, and in the late stage, they are dependent on a caregiver for activities of daily living. So that particular need, definitely most people will look after, but it is improving emotional health, social health, and spiritual health, which matters a lot for both the patient and the caregiver. So just by putting my father with his friends in the center improved his emotional health a lot, because he had a purpose. He could come to a center. He could be useful. His friends would talk to him. Students would talk to him. The children with hearing impaired would communicate with him, because even they could not speak and my father could not speak, but they would communicate and develop a bond. That was very, very helpful. I still remember for about a month our house had a road which was dug up and I could not take him. So I sent him to a physiotherapy unit which was next door to our house. He was not at all happy because the interaction with these kids he was missing, and he would refuse to go to that center and he would insist that I take him to my hospital where he had a better chance to interact. So emotional health is very important. His social needs were taken care of because he could meet his friends, and of course spiritual health. Spiritually, he was not highly religious person, but I knew he was very, very spiritual in the sense he was intimate with his own soul. And for my mother had lots of spiritual needs which we looked after. So early dementia, when dementia is just limited to hippocampus, where only memory issues are found out, what are the issues that we faced and many other patients face? He used to always misplace his things and then try to search for it, and he wouldn't find it because he would have forgotten where exactly he has placed it, and he would think that there are thieves inside the house. And he would always miss his purse, and he would say there's no money, he's not finding any money, etc. So my mother would always put some change in his pocket, 10 rupee, because he was not able to recognize whether it's a 10 rupee note or a 100 rupee note, because his concept of 10 rupee was an old 10 rupee note, and we didn't have that. So my mother would always put some currency in his pocket, and whenever he said no money, she would show his pocket and he would take it out, and he would be happy that there is money in his pocket. And whenever he suspected theft, and whenever my mother called that he's behaving abnormally, I would go and ask him what is wrong, and he would say there is a thief, and I would call the police and I would say the police are coming right now to investigate, and within no time he would be all right, and he would have forgotten about it. Failure to recognize familiar people, that also happens because their memory of the familiar people is an old one. So his memory of my mother was when my mother, maybe he had gone around 30-40 years back, where my mother was very thin and she had lots of children. That's what my father used to say. My wife is a very frail person. She had many children. I neither find the small children or my wife. And there's another lady who's sitting in my house. So we agreed with him that his wife is somewhere else, has gone home, and children are also there, and this lady has just come to cook food for him and help him, and that would calm him down. And of course, after reverse treatment, he started recognizing my mother, which was a very great thing for my mother, because my mother would be so upset because she would serve him so much, but my father would come and say, a thief is there inside my house, she's trying to steal everything, she is after my gold. He would have a ring which he would take out and give it to me. For some reason, he would still recognize me and my eldest sister, but rest of the children he would not recognize. So at least I was happy that he was recognizing me, and we were somehow trying to manage that. Repeated question can be bothersome. My father wouldn't do that, but we see quite a few patients keeping on asking the same question again and again, and it's quite bothersome and irritating for some. Sudden disappearance happens even in early stages. Even my father had disappeared in the middle of the night one day, saying that today is my daughter's school day, and I have left my wife there. I have to go and pick her up. And he had just disappeared in his home clothes in the middle of the night. And he came back home, and when we asked where did he go, he said, I went to Lady in school. It was so-and-so daughter's school day, and I came back home leaving my wife there. So this is a cause for in early stage, the disappearance. It's not that they don't know the way or they are disoriented. His mind went back to the school day that happened on maybe 30 years ago or 40 years ago on that particular day, and he probably in the middle of the night he woke up on that day and he remembered every event of the day and he went out. So we understood him that this is what happens. After that we were a little careful, we were locking the house so that he doesn't harm himself by disappearing. He was depressed in early stages, very much depressed, and he was very anxious also. He was very anxious about whatever little money he had and what will happen to it. And he did ask for making a will, and we did arrange for it. And when I look at the will, that is the most sensible will that he has is made. Even the most sensible person wouldn't make it. It was he had hidden it from us, but we took it only after he passed away. And he had mentioned that whatever property is there, it should be divided equally among all children. But after his death, it should go to his wife, and after his wife's death only, it should be divided among children equally. And he had made all that arrangement so that children don't fight. So I was amazed. He had early dementia, but he had the sense to make a will which was very, very well made. So this is what we were doing. We were believing that whenever he suspected theft, that we would call the police, and we would also go around, search for his purse, divert his attention, and trying to calm him down. These are things that we were doing for him. So even whenever he said this is not his wife, we said this is a lady who has come to help him. And we were slowly even teasing him, do you like this lady? He would say, yes, yes, she's pretty efficient. And she follows me wherever I go. I feel a little embarrassed because people will think that we are married and it is going to look silly and all that. And we used to always tease him, shall we get you married to this lady? And he would say, chi, at this age people will laugh at us and all. So he would remember that he's old to get remarried also, and we used to act like that. And I still remember that we went for
Dr. Joshi, I'm on the line. I'm listening to her talk.
Yeah, so we even went with the idea that yes, he is. We talked to. We went and had a family trip, and my mother also came. She said, "Is she also coming?" Yes, because you need some help, no? So she'll come. So then he would be puzzled because when we went for a Govt trip, there was a cousin of ours, and my cousin recognized my mother and spoke to her. How does he know her? I thought she's a lady who's come and stayed in my house. He knows her. That's what he used to say. No. He has seen her. He knows. He also thinks she's a nice lady. So it's okay for you to get married. That's what we used to tease him, and he would laugh. So it was a good time we had where we believed that he's in love with my mother all over again, and it was very, very nice without contradicting. So this is what we used to do. Again, money handling was a big issue because he would write down checks again and again. He would say, I have to pay his income tax officer, he has to pay his income tax, and again he would write a check for income tax department, etc. So my mother would go and fight and snatch away the checkbook, etc. So that would irritate him a lot. And then what we decided was give him some old checkbooks which are outdated and keep it for him so that he can write any number of checks and then give it to anybody, but it won't be valid. And we inform the bank people also this. Again, their judgment, etc., will be poor, so people can fool them. They can take away their entire money and do everything. So we were very careful with that so that his money will not be taken by others. So there were he would get very, very anxious because whenever he wanted to write 2003, he would write 2000 like this and then 3. And 10,002 would be like this. So when he would write a check also, it would be like that. Like if you want to give a check of 1,002, he would write 10,002. So this is how he used to write. And sometimes it could get encashed, and then he would be in trouble. And even addition, he would have problems because he had the habit of writing a diary, and he would add up whatever he has spent, and he would write numbers like this 2003, and then he would get very much worried that he spent a lot of money. So this also I had told. And one fine day, actually, he had disappeared at 7 o'clock in the morning, saying that he has to meet the auditor. Again, orientation to time will not be there, but his mind says it's time to pay the income tax. And he had disappeared and gone. It was a holiday, and my mother had just given him his morning coffee, and he was not to be found. We went from pillar to post searching for him in his familiar places. We could not find him anywhere. And we even reported to the police, and some police had said that there was a report of a person who was met with an accident, and even we went to even that spot. Thankfully, that was not my father. And when we returned home with so much of depression, 6 hours later, he came back home. He had gone in his morning dress, not even chappals. He was extremely dehydrated. I don't know how many miles he had walked, where all he had gone. When we asked, he said he went to income tax office, he went to his old college, he went to his second college where he was teaching, he was the director of a business school. A third college, he was teaching physics. And he has visited all those places and found everything closed, and then he has found his way and come back. He told the income tax, mainly he went to pay income tax, but the office was closed. Then he thought he'll go to his college and see what's happening, and that's how he has roamed all the places. But he had found his place back, and he had come back home safe. Thankfully. But there are people who have gone out like that and they were not found at all, because after they walk for hours together and days together, they look like beggars, and then I don't know where they would reach also. I still remember a pediatrician recalling that his mother had walked and reached a village about 40 kilometers away, and dogs had attacked her, and she was bleeding like hell, and somebody saw and rescued her, and he found his mother. And then after that, he could not take care of her at home, and he had to put the mother at home. So when all this happened, I knew that 24-hour watch is required for my father, and this is where I decided to keep a home nurse for my father. And after that home nurse was all the time following my father, and he was not lost after that. When they go into moderate dementia, where parietal lobe and prefrontal cortex also starts getting involved, the familiar tasks become very, very difficult. There's no weakness of any of the muscles, but they will be unable to do their simple tasks, like they don't know how to do it. They don't know how to bathe. They don't know how to dress. They don't know how to cook. My father had great difficulty in getting into a bathroom and getting out of a bathroom. He would enter the bathroom, and then to come out, he had to put a step out. He would think it's a train or something like that, and if he puts his leg out, he will fall. So it was very difficult to make him come out of a small bathroom. Then we would sort of help him and sort of divert his attention and make his exit from the bathroom an automatic one without thinking, then he would come out. So it was a very difficult thing. So after it affects both parts of the brain, even the speech becomes incomplete. That's what happened to my father. He would start off with a sentence, and then he wouldn't complete the sentence. And of course, then face recognition also becomes an issue. That is what we call as agnosia. So very often people call them as aggressive, but I don't think they call me. I never ever thought my father were aggressive. There was a reason behind aggression. So if I followed the event before the aggression, I would know why he was aggressive. So there is always an antecedent cause for aggression. It could be something that he has lost. It could be an irritating question somebody asked. It could be something which triggered the aggression. So always, if I just ask what happened before that, I was able to handle his aggression. So in early dementia, keeping them active physically, mentally, socially, spiritually is very, very useful. The daycare center that we created exclusively for my father, where all normal, healthy people joined for healthy aging, was very, very useful for my father. And today also I'm happy it is running with nearly 500 members. And because of COVID, they are not able to join together and exercise. They have gone online and they are continuing to do the exercises. So I think this has been talked about. Fall risk is very high. My father did fall and he did have an intracerebral bleed and a subdural hematoma, and the doctor's attitude to dementia patients is extremely, I would say, bad, I would say, because they think patients with dementia are cabbages and we should not do anything, we should allow them to die. In fact, a neurosurgeon who saw my father when he had the subdural hematoma and intracerebral hemorrhage, he said, I will not touch him because after the surgery he is going to be a cabbage. And it's better that he dies of the intracerebral hemorrhage. I did not agree. I said my father is not a cabbage. He has feelings. He may be demented. He still understands love. He still knows that I am his daughter. So I want my father intact. You go ahead with surgery. Whatever, if he dies during surgery, I have no issues. But I want him to have the surgery. And I gave the consent for surgery, and he did have a subdural hematoma evacuated. And post-surgery, although he could not speak and could not walk, we could still take him in a wheelchair to his exercise center, and he lived for 4 years. And my mother was very happy because he could still recognize my mother for the 4 years, and he would give a beautiful smile to her. Every day, whenever I took him out, he would do tata to her and give a smile. And when we returned home also, he would give a smile, and that made my mother's day. So treating physical symptoms are very important. So falls intervention, actually I should have taken care of that. But in my father's case, the fall was very, very peculiar. The caregiver and my father were sitting in the room. My father was sitting in the cot, and my caregiver took out a book to write his account. And my father said, it is my passbook you have taken, you give it to me. And in a hurry, he got up to snatch it off from the caregiver, and he fell. My father has postural hypotension, and that's how he fell. We did address his postural hypotension later on, but at that moment, he suddenly got up and he had a fall. Incontinence, of course, we need to take care of incontinence, especially in mobile elderly. We have to put a big board to the toilet because very often they may not find the toilet, and that's why they are incontinent. And we should keep the toilet light on at night so that they will know where the toilet is. That's for every elderly, I would say, we should do this. Dressing apraxia they'll have, but if you arrange the dress in an order, they'll be able to dress themselves. Bathing apraxia they'll have. If you keep everything ready and initiate the bathing process, they will be able to take bath on their own. My father was able to take bath on his own until he was able to walk. And when they don't recognize people, we have a very irritating nature of all people. They come and ask elders, do you remember who I am? Even my students, I am now 63, my students come and ask, can you remember my name, madam? Can you tell me who I am? I can't remember, definitely. I can't remember their names. So it's better that And if I have dementia, it will distress me a lot. I will think that this person must be a very familiar person. I'm not able to name him. I try to retrieve, I don't get it, and I get agitated. So it's better that they start the conversation saying that I am so and so, I love you, this thing, you have done this to me, you were my teacher, I loved this. Immediately there'll be a sparkle on the face of the dependent person. My father's innumerable students would recognize him whenever we took him out for walk or whenever we took him out in a wheelchair for function, and they would come and wish him, and he would acknowledge and then wish back. And they would come and introduce, and he would be very happy. So that's the way it should be. Nominal aphasia, when we have to help them with words rather than trying to make them say that. So they may have difficulty in naming. If you supply the word, they'll be able to complete the sentence. Again, my father's had sensory aphasia, where he would start a sentence but would not be able to complete it, or some abnormal words would come. I would always, by the tone of what he was saying, I would understand and I would complete the sentence for him. And he used to also go for speech therapy. We have to maintain dignity at all times. Some of them may have disinhibition, like undressing. It is just because they are they think that they are in their own bathroom or whatever it is. I have come across a lady who used to think that she's full-time in labor and she has to deliver. So it was very embarrassing, but in front of everybody only she would lie down and go into the lithotomy position. So the doctor-in-law was very smart. Whenever she said, labor pain, she would take her to a room, put her on the cot, and she would be in the position to deliver. And then after some time, she would forget and come back. So this is what the doctor-in-law used to do. So we should maintain dignity and help them, because it will be, if you observe them or talk to them, we know where they have gone and why they are doing it. Hallucinations, they may have, it is not actually hallucination. They go back to the world of their own. If you understand to which world they have gone to or which era they have gone into, and you become a part of that era, it won't be a hallucination. For my father, it was always his college day, his students and things like that. And we would understand those scenarios, and we would always say, no, college day they have postponed for this reason, so it's not there today. So tomorrow we will go, something like that, and you go to calm him down. But if they develop acutely a confusion status, we have to rule out infections or chemical imbalance and then help them out. My father would worsen with every acute febrile illness or any other disease he had. So constantly family support, legal issues, driving could be dangerous for people with dementia. But however, if there is a person sitting next, and if they are able to drive to a known destination, it can be allowed. But I think officially they are not permitted to drive. Very early dementia, if they're only going to a known destination with the assistance of a person, they can probably drive. So we have to look into that. My father long back stopped driving because of his vision problem, so we did not have that problem. Antipsychotics, I managed my father and his aggression without any antipsychotics. Of course, the psychiatrist of dementia had prescribed olanzapine. One day I gave quarter dose of what was prescribed. He slept for 2 days, didn't eat any food. It was pathetic for my mother. So after that, I decided not to give any antipsychotics as we understand him better. So these are all the side effects of this thing. So only if, say, their hallucinations and delusions cause harm to others or self-harm, then we have to use antipsychotics. I had a patient who was constantly lifting heavy things and throwing away because he wanted to arrange the house to probably to a level to the house which he sees in his dementia state, because maybe 40 years ago the house was, he wanted it to be arranged that way. So he would lift everything and then arrange it, and it would probably fall on his wife or on his feet. We did have to calm him down with a small dose of ketamine because it was harmful. So otherwise, we should not use antipsychotic medications. So activities are a real good boon. If they have activities the whole day, definitely their behavior also will improve. The daycare center was a very good intervention for my father, but not many people can have a daycare center in their own workplace. I had a daycare center which I created in my own workplace. However, they can be dropped there and picked up, and they will be very, very happy in the company of senior citizens and caregivers there. Music is another thing that can calm them and bring back old memories also. So my father was not a very great person for music. However, he did have some favorites which would play for him every day for 1 hour or 2. Therapeutic recreation like games and dance and things like that are very good. Exercise program, we did enroll my father in complete exercise program when he was walking, and later on passive physiotherapy by physiotherapists. Even brain exercises, cognitive stimulation exercises are very, very helpful for dementia patients. It will be like simple things which they can do, what they remember. So we always take them to their childhood, which they often remember, and talk about their childhood and childhood days, what they were doing, or who was the president of the country at that time, who was the prime minister at that time. All those things, they are very happy. So delirium, we should always recognize whenever they acutely deteriorate, there is a treatable condition. We should recognize the treatable condition and treat them and bring them back to the original state. When they reach the last stage, actually the previous speaker also was telling, it is more of nursing needs rather than other needs, because there is no behavioral issues there. They are not even talking. They may be understanding still something. They understand love. They understand sadness. So you can't take it for granted and say they don't understand anything and talk some bad things in front of them. So it is good to be expressing only love. Activities of daily living has to be taken care of by a caregiver or a nurse. Swallowing may be difficult, and even we have tried like finger feeding is always better, because they go back to childhood. Maybe they are like 1-year-old child or an infant, so those tactics work. Even they say, even instead of putting a tube to the nose, even feeding bottle and liquid feeding through feeding bottle is a better option than putting a tube. However, socially it will be embarrassing. So none of the relatives I have tried agree for a bottle feeding, but they are okay with finger feeding and giving some semi-solid food by finger, and that is to an extent that is possible, and they opt for rice cube rather than bottle feeding. And the issues of a bedridden patient with pressure ulcer, incontinence, sores, etc., recurrent choking because of aspiration, these are all the issues. As I said, skin care, etc. I was talking about pain. Actually, pain in dementia patients is often unrecognized, and it is not at all recognized. Even in my father's case, he got admitted for an acute problem. I think he developed a cellulitis, and one day he did not move his leg because it was very painful, and that one day of immobility in the hospital itself produced a pressure ulcer, and it took about 6 months to heal. So for the pressure ulcer, I was taking him to a surgeon every day. He would do debridement, and they would say, your father is so cooperative, he is not even batting an eyelid when I cut it without local anesthetic. So when he said that, my father was not able to talk at that time, he screamed. That scream is still in my heart. He screamed so loudly to express that he does get pain, and it is really painful. From that day, I stopped taking him to that surgeon who was cutting his wound, and I just kept him at home and did honey and metronidazole combination dressing, which was doing auto debridement for the wound, and the wound healed beautifully without even a scar. It took 6 months, because even with the debridement and surgical procedures, the surgeon had said it will take 6 months. But without any pain, I managed his wound with home dressing. I stopped taking for debridement and that kind of a thing. So again, to prevent, my father used to choke a lot, and almost he was near choking was happening many times. Still, we managed to finger feed him till the end. So this is some pictures of cognitive stimulation activity happening in the center that I created for my father. The 2 social workers are actively helping. This is a music therapy that we have tried on dementia patients using an instrument called as body tambura. This is our Mangalore page observing World Alzheimer's Day. Page is nothing but People's Association for Geratric Empowerment, where all the people caring for the elderly come together and observe this September month, and we talk about dementia and we promote care for support for dementia patients. So this is my father. This is the daycare center where so many people are coming. This is a caregiver forum that we have formed. And every year, we launch Alzheimer's Day on the 1st of September in a park. But this time we have not been able to do. At least we want to have a valedictory in the park with social distancing. So I conclude saying that we should be the pallium. Pallium is a cloak for dementia patients, and we should protect them from the insults they get from the society, and we should sensitize the society to become the pallium for dementia patients. Our dementia patients should be able to live freely in a dementia-friendly community. It is their place, it is their community, they have built it up. And when they think that they have gone back 50 years ago, we should also go back with them to the 50 years ago, what they saw, and we should see the world with their own eyes, and we will probably learn a lot of things. So thank you very much for a very patient hearing.
Hello?
Yeah.
Hello?
Yes.
We
Hello?
can hear you, Pratibha
Hello?
madam.
Hello, can you hear me? Can you hear me?
Yes, yes.
Yes, Pratibha.
Prabha?
Yeah.
Yeah,
I'm here.
Hi. You always bring out the soul in any subject, in any topic. And you brought out the soul today. You enter into the subject with the person, and I could feel, because I have seen your father when he was so active, absolute memory, and with you, I could see your father losing his memory, and and when I used to visit Mangalore on and off, I used to come to your place, and out of the blue, he used to smile at me, he used to know I'm somebody important to you. I can remember how he progressed, and you brought this topic out beautifully through the story of your father. It was a lovely learning experience, taking what it means to be in a mild, moderate, and severe. What are the clinical features? And what came out of your topic today was medications are not everything. You could give your father a quality of life without medications. There's a lot more in dementia other than medications and treatment, which I think is the most important part in management of dementia. It's my honor and pleasure to introduce Prabha Adhikari, my very good friend. In fact, her mother used to call, I'm the 9th daughter of the family, and I have spent wonderful, if today I'm strong in my medicine, as along with my teachers, I owe to Prabha, who taught me what clinical medicine is all about. She took medicine department of KMC to great heights, brought in new innovations, started new things, and ended up with flying colors. She went out with the head held high, and she's now in Yenepoya doing the same thing, bringing up the organization to great heights. And Prabha has wrote many research papers, which is of high degree of quality, and she has been author of textbooks, and she has created a niche for herself as one of the greatest physicians, and her acumen for diagnosis and clinical judgment is excellent. Prabha, it was a pleasure listening to you, and I'm sure everybody would have learned a great deal through your lectures. Dr. Hanuman, I thank you for giving me this opportunity to speak about my friend, a great teacher, a philosopher, a mentor, a great clinician, and above all, a great human being. Thank you so much. It's such an honor for me to do.
Madam, can you please click on your video so that we can see you at least?
I don't know where I want to click, but I don't know where to click.
No, there is a...
yeah, I got it.
Yeah.
I got the video. I got the video. It was right there. It was right there and I didn't know. So that's why I think Dr. Hanuman was sending me a message, are you there? Are you there? I said, I'm there.
Madam, Dr. Prabha Madam, it was really both. Number one, very informative. At the same time, it was very emotional also.
Yes.
Because what you have taken, I think there are a lot of people to love, definitely. But when it comes to the care, it is always a challenge. We really appreciate that. And when I was listening, we have been a part of so many webinars. But such an informative webinar, completely involving in it and sharing your own life experiences was fantastic, madam. We have learned a lot from you. And are there any questions to ask Rosie? If there are any, please ask, madam.
No, sir.
Yeah, there is one.
I want to ask.
Madam, yes, madam.
How do we differentiate in management? Is it the same, Alzheimer's or multi-infarct dementia or whatever? At which point is there difference? At which point it's the same?
I would say pure Alzheimer's disease, if you take, the deterioration is very slow. So, whereas if they have vascular dementia, the deterioration is much faster. So we need to manage comorbidities more optimally if it is vascular dementia. So in my father, it was mixed dementia. He had Alzheimer's as well as vascular. That's why the initial deterioration was very, very fast. So optimizing blood pressure control. When I say optimizing, it should not be too low. It should not be too high also. So it should be real optimum where blood perfusion to the brain is optimally maintained. If they have diabetes, again, the sugar should not be too high, sugar should not be too low. Cholesterol, these become important. So comorbidity management becomes important. And if you optimally manage, there also we can prevent deterioration. Because after I understood that my father had dementia and I managed his comorbidities better, then the cognitive slowdown was very much decline. There was decline in cognitive loss actually. Whereas physically he lost because of the fall and the intracerebral hemorrhage that he had. But otherwise, because I understood that he was having a severe postural hypotension, that means on standing his blood pressure would drop, and that was the cause for his fluctuating cognition. I was telling that he would recognize my mother in the morning, and the evening he would have forgotten who she was. That is because he would walk, and then the brain would lose its perfusion. He would be standing and walking the whole day because he used to enjoy walking, and the brain perfusion would decrease, and by the end of the evening he would have forgotten my mother. And again he goes and lies down, the circulation would improve. Morning he would recognize my mother, give the sweetest smile, take coffee from her and praise her coffee, then go out for walk. While coming back, he would have forgotten her. So that was the blood pressure issue which I recognized, which I managed optimally, and that improved everything. So vascular dementia, the deterioration is very rapid, and optimization of these things become important. Pure Alzheimer's deterioration is very slow. I would say it is 3 score per year. That is, if you take MMSC, they decline by only 3 score every year. It is slow. It is over 10 years maybe. So vascular can be just few 1 year or 2 years. They can just go down to the last stage.
There are some dementias, they present only with hallucination. Lewy body dementia. So how does one manage this?
Yeah, again, there is a scope for antipsychotic medications, a small dose probably. A very small dose of quetiapine is what we use, which controls hallucinations. And they have severe Parkinson's symptoms also. The body is rigid. So small dose of anti-Parkinsonian drugs are also pretty useful there. Beyond that, we do use cognitive enhancing medications, but the downhill progression is very fast there. I feel in about 3 to 4 years they are in the last stage, and relatives can't accept it also because it's again very rapid despite everything that we do for them.
Suppose I don't want to develop dementia, any exercises for me and Dr. All of us who are here, what do we do?
Yeah, I would say the same. Prevention is definitely better here, and we should go on spreading the message for the elderly people to manage the risk factors well. Okay, so we will start. There are some childhood risk factors also. That is not under our control, but midlife risk factors are very important. Control of blood pressure adequately in midlife, 40 to 60 age, where we neglect our blood pressure. Controlling our obesity in midlife, and controlling our, many of us develop hearing loss in midlife. So, and we don't want to accept, we don't want to wear a hearing aid, we don't want to do anything, we still spoil our ear with noise pollution. So protecting our ears in midlife, these are the 3 things that we can do if anybody is between the age of 40 and 60. Once you cross 60, remaining socially engaged, whatever mode we have now, WhatsApp, we have these online meets where we can meet each other, we can meet old friends. We have to remain socially connected. When I say socially connected, it's not just doing WhatsApp and watching. It is active talking like this, seeing each other, giving smiles, exchanging pleasantries. That kind of socialization is absolutely required. Physically engaged. So aerobic activity. The minimum required is 30 minutes. We can do more than that. If you can't do 30 minutes at such stretch, 10 minutes. Actually, yesterday we had a lecture by Dr. Varsha about exercise. She said you eat any number of times, but after eating one time, 10 minutes exercise has to be there. So if you are eating 6 meals, 10 minutes after each meal or before each meal. So that's a very good concept. We eat, but we digest it with exercise. So that is a good thing if we can't do 30 minutes or 60 minutes at a stretch, because elderly people find it very difficult, frail elderly especially. So at least that, and accumulate around 30 minutes of aerobic activity. Then third thing is brain stimulating activity also is very important. So again, simply watching TV, simply reading messages of WhatsApp and simply forwarding to people, you are not using your brain. So you have to use your brain. You have to use your brain. Reading is a good hobby. Writing is a good hobby. Learning a new language is a good hobby. Learning something new, music, dance, anything can be a very good activity for the brain. And simple things like doing household work is a cognitive activity. Cooking, it is a cognitive activity. You have to think, plan, everything is there. Execution is there, everything is there. So even doing a household work, even if you want to sleep, you'll have to really think a lot. So doing household activity itself is good enough. You can do all that. Then the fourth thing is avoiding depression. when we retire, it is depression which is going to affect us. All of us think we will work like this forever and we will be active and everybody will say how, who and all and praise you. We should have that reality. When we retire, everybody is going to forget us. All our students are going to forget us. The house people are going to give us a place which is much, much down. Even if we are independent, we will require the help of our children. Our children will become our bosses. We should remember that. So we should not go into depression because of that. We should be prepared. Either plan to live independently in a home or plan so that you become your own boss, like my mother is. She's 94 and she lives downstairs and she wants to be independent. Recently she had COVID, a very bad one, and I have shifted her to my house and I had told her henceforth you have to live with me. She agreed when she was sick, but once she's little better, she's very upset that she's lost her control, and I have now made arrangements to push her back into her own house. Well, she said, I'll be the queen of my own house. So you plan like that. You live close to your children and then be the queen of your own house or king of the own house and don't get depressed. Then of course, bad habits like smoking, alcohol, we have to give up. Even if we are old, giving up has a good effect on the brain. Manage all the comorbids, diabetes, blood pressure well, and that's it. So we have to have a plan to continue to work, continue to serve the society at least. You should not be stressed with work. It should be to do something for the society where you are free to do what you want to do and continue to do something useful for somebody. It will make your day. It will spend every day happily. That is important. Get good sleep. So this is if we do all that, I think 50% chance of getting dementia is cut off. Age is there, we can't do anything. Gender is there. Females are more at risk of dementia. I can't change my gender or age, nor my genes. I am getting prepared to get dementia also. Even if I get dementia, because dementia patients are very happy. So I'm going to tell my children that this is how I want to be treated. I want to live in my own world. Allow me to live in my own world with assistance. That's what I'm going to tell my children also. So even dementia patient can be very, very happy. It's a society which makes them unhappy.
Dr. Prabha, there are few observations and there are questions. One is from Dr. Rajesh.
Yeah.
I think he has a doubt rather than a statement. Intake of an antioxidant, and nutritional food. And early aging and dementia.
Yes. Yeah, definitely nutrition is very important, but directly there's no association between nutrition and dementia. However, this nutrition has impact on the comorbidities like diabetes, hypertension, obesity, everything it will control, and stress reduction, so good sleep. So indirectly nutrition is very, very important. Taking antioxidant rich diet rich in nuts, it's supposed to improve cognition, curcumin. So these are all cognitive enhancing substance that's there in our own food, and taking a balanced diet, high protein. So this is all going to help. Definitely nutrition has a role. Because without nutrition, you cannot manage hypertension, diabetes, obesity, etc. and against stress.
Dr. Rosie? Pratibha madam?
I'm here. No, there's lots to discuss, but I think, yeah, thank you so much. I really enjoyed the session.
Rosie?
So I'm going to go for yearly check of my, cognition and memory. So I think we need to do that.
Yes.
Definitely we need to do that. So we are doing that. We will all undergo memory testing this month.
Absolutely.
Definitely my memory is much worse than that of my mother. My mother is 94 and fantastic memory she has. And every time I check, I get a score of 26, 27. She gets 30 out of 30. So I have to check whether it is declining. And Pratibha and myself always have memory loss. I still remember what all we have done when we worked together. One fine day, I think Pratibha was searching for a stethoscope. We searched all over and then she started laughing. I had 2 stethoscopes in my neck. I had taken hers and put it on my neck. And I still remember Pratibha. She used to drop me home most often because I didn't know how to drive. It was she who motivated me to learn driving. So she would drop me home. And one fine day we came out. Pratibha said she'll drop me home. Then she said, "My God, where is the car key?" She searched her whole bag. She didn't find it. Then we searched for the key all over. Every ward that we went, we searched. We didn't get. And then she called her husband and said, "The car key is missing. Car is also missing." We searched for the car is also not there. Then the husband said, "You didn't take the car only today. The car is at home."
Fantastic.
So this is our memory when we were in 40s. Imagine how it will be now. So we always tease each other from memory. We will sit together and we will be having similar looking spectacles and we will take and put some her spectacle I'll wear or sometimes double spectacle I would have worn. And I don't know. So these things we do every day and we know that we already have memory loss.
Yeah.
It's really nice to be in association with you. Actually, Pratibha madam has been very instrumental in inspiring us to start a PACE chapter here. We are in the beginning stage, and we are very soon. I think we can bring it to the proper track. And definitely, we need your guidance.
Yeah. I'm a part of anything that you do because you've been very active in Alzheimer's, and I'm happy to be associated with you. And Mysore chapter has done wonderfully well, RDC. We are not able to start a RDC here, but we have brought all the groups working for dementia together. That's what we have done. I think it's high time we start a chapter as well and get guidance for people like you because we also need guidance from people. So thank you so much.
Rosie, can you convey the word of thanks quickly?
Yes, sir.
Yeah.
Good evening, all. I would take this opportunity to thank RC, Mysore chapter, for giving me this opportunity. Firstly, I would like to thank Dr. Laldinpuii Fente, Secretary, RDC Mizoram chapter, for sharing her valuable knowledge and providing study inputs regarding dementia issues. And I would secondly thank Dr. Robert and for giving us salient inputs with respect to the dementia signs and symptoms. And I must mention our deep sense of appreciation for Dr. Prabha Adhikari for her explanation on topic palliative care needs of patient with dementia. And I would also thank Dr. Prabha for her presence. And finally, I would thank Dr. Bhagyashree for moderating the webinar. And I thank Dr. Hanumantachar Joshi, Principal, Shadavilas College of Pharmacy, President, RC, Mysore chapter, for providing this opportunity and for his immense support to make today's webinar a great success. I especially thank all my colleagues of Shadavilas College of Pharmacy for their support. And last but not the least, I thank all the participants for sharing your valuable time. E-certificates will be provided through a feedback form to your registered email address. Thank you.
Thank you.
Thank you.